Hello everybody, I hope you can hear me well. Uh, I hope you are well. Good afternoon, this is Dr. Khalid Alawi. Actually, I'm a board pediatrics with OMSP specialty board, which is Oman specialty board from Sultanate of Oman. Actually, I finished 1 year from in pediatric cardiology, and I would like to share with you a case that has been encountered in our National Heart Center. So this is Oman. If anybody of you know her, you can see that where it is in the map. And okay, so let's start our case with B. This child actually, our baby, has presented in the 11th day of life. He was being referred to our National Heart Center for evaluation of a cardiac murmur, low saturation, and edema. His history begins, he was born at term with spontaneous vaginal delivery with good Apgar score. Initially, he required only initial steps, nothing else, in the local hospital. But at around 24 hours of life, he has noticed by the physician that he's having a cyanosis with heart murmur. So at that point of time, he was transferred to a regional hospital. Apparently, this child was doing well there in the regional hospital, and he was at that point of time awaiting to be transferred for further evaluation to our National Heart Center, when he suddenly collapsed on day 5. It was reported that he was having a severe desaturation with metabolic acidosis. So what they did is they intubated the child, ventilated him, and started him on prostaglandin infusion, along with other supportive measures. Going back, for the prenatal history, the mother is gravid, a 5 mother. There was no antenatal risk factors, and there was no history of infection, neither significant medication intake during pregnancy. Though the antenatal scan shows a complex heart disease, but there was no extra cardiac anomalies. This child was born for a consanguineous parent, but other siblings were all healthy.
Okay, Khalid, let us ask the participants whether they would like to know anything more from you regarding history. Mirza, Rajesh, Vinod, are you happy with the history, or do you need anything more in the history that you would like to know? Khalid has told us about a baby which was born term and which was found to be having severe edema and cyanosis. On day 5, this baby was collapsed. A baby was found collapsed. The baby was ventilated, started on prostaglandin, and referred to a tertiary care center. This is the story that he has told us so far. Is there any other details that you would like to know? And Khalid, look for your chat box. They would send us questions.
Yeah, sure. So chat box.
You have found the chat box?
Yes, yes.
So any questions? Otherwise, I would like Mirza to tell me what he thinks from this history. Mirza, what does this history suggest to you? I need a quick response. Yes? You think it's a duct-dependent cyanotic congenital heart disease? What do you mean? Why do you think that this is a duct-dependent cyanotic congenital heart disease? What is the most glaring aspect in this history? Not necessarily Mirza, others can join in the answer. Yes, Mirza, the child deteriorated on day 5. The child had a collapse on day 5. That is what Dr. Khalid said. Rather than say that the child had a worsening of cyanosis. Yes, this was a cyanotic baby which collapsed on day 5, and he also said that the baby had generalized edema. Is generalized edema a feature of typical duct-dependent cyanotic lesions? Isn't it rather unusual? Have you ever seen a TGA baby come to you with generalized edema? Any other comments from the participants? So what is unusual in this baby is that here is a baby which had an antenatal diagnosis of congenital heart disease, which was born at term. Cyanosis had been noticed on day 1. The baby was apparently doing well, but the baby had edema and the baby had collapsed on day 5. Khalid, have I got the history correctly?
Yes, sure.
Okay. Yes, Vinod believes that it could be hydrops. This question Khalid needs to answer. Khalid, was there edema at birth?
No, according to the physician who wrote the note, the child was absolutely fine at birth.
Okay, so Vinod, did you get that? This child was normal at birth in appearance. Edema developed over the next few days. So hydrops is out. You were quite right in thinking that it could be hydrops. From the history, it may not have been clear whether there was edema at birth or not, but Khalid is emphatic that the treating pediatrician had told him that the child was absolutely normal at birth, but for mild cyanosis. So the question of hydrops doesn't arise. So the question is, what could cause right heart failure, edema if you equate it with right heart failure, what could cause right heart failure to appear in the first few days of life, from day 1 onwards? Epstein's anomaly, very good. Very good, Vinod. Yes, tell me other conditions which can cause right heart failure. In Epstein's anomaly, it is because of severe tricuspid regurgitation, and Epstein at birth, is in the first few days of life is very likely cyanotic because of the high pulmonary vascular resistance. So cyanosis with right heart failure could go with Epstein anomaly. That's a very good choice, Vinod. Does any other possibility occur to you? Very good. Who says tricuspid atresia with restrictive ASD? That is Vinod. Vinod thinks it could be tricuspid atresia with restrictive ASD. Okay. Very good. Any other possibility? Epstein, tricuspid atresia with restrictive atrial septal defect. Can there be some other cause for tricuspid regurgitation in a cyanotic baby? Pulmonary atresia, intact septum and tricuspid regurgitation. Excellent. That is again Vinod. Pulmonary atresia, intact septum and tricuspid regurgitation. These are possibilities that we would try to exclude as Khalid continues with his presentation shortly. Any other condition? No, I'll take you in a slightly different track. See, these are all conditions of right heart failure, and you're quite right. But this cyanotic baby, let's say, had gone into shock on day 5. Does that go together? Does a TGA go into shock? A TGA can, of course, go into severe desaturation and acidosis. But if a cyanotic baby goes into shock, what would that suggest to you? Hypoplastic left heart syndrome is not exactly cyanosis shock. In any shock, of course, you can consider hypoplastic left heart syndrome. To that extent, you are right. Pulmonary atresia with a duct-dependent circulation will not go into. Pulmonary atresia with a duct-dependent circulation will go into profound desaturation when the duct closes. The patient doesn't go into shock. Which cyanotic congenital heart disease is associated with LVOT obstruction or arch interruption? To put the question plainly to you. Toxic being, very good. So, if a cyanotic baby is going into shock, toxic being should be considered. Shock in the newborn cardiac context. Shock in the newborn in the cardiac context always makes you think of LVOT obstruction or coarctation, where the ductus closes and the baby goes into shock. So toxic being is the prototype of the condition where this can happen. It can also happen in TGA, but it's much more classical of toxic being. So just remember that also in the possibilities that can occur in this patient. If this baby had a TGA or a toxic being, and if the duct is closed, the baby remains cyanotic, the baby crashes and remains hypoxic, acidotic, and in shock. What other conditions? Presents with cardiac failure, shock, and acidosis. Can TAPVC present this way? The question was, can TAPVC present this way? No response. Khalid, what do you think? Can a TAPVC present like this?
Yeah, actually not in shock, but it can be explained other two parameters, like for example, the edema and cyanosis at day 5 of life.
Okay, the severe cardiac failure and cyanosis can go with an obstructed TAPVC. In fact, an obstructed infradiaphragmatic TAPVC presents with hypotension and cyanosis. Yes, now we know this thinking about it, and all of them have caught on to that. And an obstructed TAPVC could present like this. The other question which I had asked before I moved on to cyanosis with LVOT obstruction or coarctation was any other cause for right heart failure in cyanotic conditions. Remember, in a univentricular heart, if there is tricuspid regurgitation, that will cause cardiac failure, and an AV canal, particularly an unbalanced AV canal, is notorious to present this way. So we have considered a number of possibilities. From this history, the things that stand out is cyanosis on day 1, which makes you think of TGA and TGA-like conditions. But this is associated with heart failure. Heart failure, we have got evidence of right heart failure now. As we go further along, we will know whether there was left heart failure as well. So cyanosis with right heart failure, we considered the possibility of Epstein, AV valve regurgitation in a univentricular heart, obstructed TAPVC. Is there anything else that you would consider, Khalid, in the differential diagnosis from the history?
So we said Epstein, we said also truncus arteriosis.
Why would you think of truncus arteriosis? Why would truncus arteriosis cause heart failure in the first week?
Because of unrestricted blood flow to the pulmonary vasculature.
Does that cause heart failure in the first week?
And especially if they have like a coarctation.
Yes, if there is a truncus with interruption or coarctation, it can be a cause for heart failure in the first week, or the patient presents with an early diastolic murmur in the first week and is in heart failure. What does it denote?
With severe truncal valve regurgitation.
Truncal valve regurgitation. So a truncus with truncal valve regurgitation can be a cause for heart failure in the first week of life. See, we are speaking of cyanosis with heart failure. When you speak of cyanosis with heart failure, you are generally in the category of cyanotic congenital heart disease with increased pulmonary blood flow. That is why the conditions that we have discussed would include TGA, truncus, single ventricle, TAPVC, all these. But if you are thinking of truncus, truncus ordinarily produces heart failure towards the end of first month. If it actually causes heart failure in the first week, it suggests that there is a arch obstruction, truncus with interruption is known, and also it could be a truncus with an with a truncal valve regurgitation. So these are the possibilities that we would consider in this baby. Do you want anything further to add in the history or the possibilities from the history, Khalid? Otherwise, I'm going to ask you to go ahead with the findings. Is there anything else that you want to tell us?
Before we move, actually, this is a child who collapsed at day 5, so infection also should be a possibility in this child.
Very good. Yeah, this is a newborn. Let us always think that when a newborn presents with shock, as pediatric cardiologists, we would always think of cardiac causes, but sepsis is a good enough and a common enough reason to cause shock in an otherwise stable baby. So let us always be sure that non-cardiac causes are excluded.
Yeah, and especially in our community with consanguineous path, we have a lot of inborn error of metabolism. We can present also like this.
Okay, so you think that you should also consider an unrelated problem where there is a metabolic disease, and that could be the reason for the shock which is occurring along with congenital heart disease, correct?
Yes, yes.
Okay. I think with that background, let's go to the findings.
Okay, so on arrival, the child to our National Heart Center, he arrived at day 11 of life. At that point of time, he was ventilated. He was having generalized edema, but he didn't have any dysmorphic feature. His pulses was 150 with good volume. All peripheral pulses were normally felt. Also, it was difficult due to the edema. The blood pressure was normal, and his saturation was 90% on ventilation on moderate setting with a FiO2 of 50. His chest exam was unremarkable. His CVS exam actually showed a cardiac pulsation which is felt in the right of the sternum. And the apex beat is felt in the right fifth intercostal space at the mid-clavicular line. And he was having normal first sound and single second sound. There was ejection systolic murmur 3/6 grade in the right upper sternal border. On abdominal examination, the liver was palpable in the left hypochondrium below the costal margin, and the gastric resonance was in the right hypochondrium. And this is to conclude our examination.
Hold on. Now, can you just summarize your findings, Khalid, once?
So basically, CVS examination shows pulsation in the right side of the sternum. There was a normal first half sound. There was a single second half sound. There was an ejection systolic murmur at the right upper sternal border. And the liver was in on the left hypochondrium, and the stomach bubble in the right hypochondrium. So he was. Shall I translate in diagnosis?
No, hold on.
Okay.
Now, Vinod, we had a list of differential diagnosis before we got the findings. Having got these findings, do you think we can go further forward and try to narrow down the diagnostic possibilities? What would you think, Vinod? Yes, situs inversus dextrocardia. We have a cardiomegaly. See, the points that you should note now. This baby has a situs inversus dextrocardia. The baby has an enlarged heart. The baby has a saturation of 90% on an FiO2 of 50. So Vinod wants to consider a univentricular heart, which is definitely one possibility. Mirza says, as it is situs inversus dextrocardia, you want to consider something else? Mirza, tell us, what else would you consider? So category-wise, we are definitely dealing with cyanotic congenital heart disease with increased pulmonary blood flow. Correct? And
yes,
we know saying that decreased pulmonary blood flow with AV valve regurgitation is also a possibility. Less likely, Vinod, because if you have a 90% saturation in a cyanotic congenital heart disease, more likely you are dealing with an increased pulmonary flow situation. If you ask me whether decreased pulmonary blood flow and AV valve regurgitation cannot occur in this patient, it is possible, but I would consider it more likely in the context of AV valve regurgitation in the context of increased pulmonary blood flow, like an unbalanced AV canal with increased pulmonary blood flow. Any other possibilities that you want to consider? I think we need more information to further narrow down the diagnosis. At this point, we would think of a cyanotic congenital heart disease with increased pulmonary blood flow in a baby with a cardiac malposition.
Okay.
Regarding findings, do you need anything more from, do you have any questions to Dr. Khalid? Anything that is not clear to you or you want clarification from?
Lower limb blood pressure was normal. Actually, there was no differential blood pressure from upper and lower limb.
Very good. These are pertinent questions. I'm glad that you asked this.
There is no differential cyanosis.
The upper and lower blood pressures were normal. Okay, so Khalid, tell us, what did you think about?
So at that point of time, we had the same thinking actually. We have situs inversus dextrocardia patient with cyanotic heart disease with increased pulmonary blood flow. So our differential diagnosis at that point of time is obstructive total pulmonary venous return and epistin anomaly as second differential diagnosis. Truncus arteriosus with truncal valve regurgitation, single ventricle with AV valve regurgitation, for example, unbalanced AV canal, and tricuspid atresia with increased blood flow and respective AST.
Yeah, actually, Khalid has listed the possibilities that we were entertaining prior to the examination so that we could concentrate on these with the available investigations in excluding these. Of these, which do you think can be excluded now from the findings? Let me put that question to others. Mirza, in this list, the findings can be considered to exclude some of these. Truncus, yes. To consider truncus with truncal valve regurgitation, you have not described any early diastolic murmur now. So before you had the findings, truncus was a possibility, but given these findings, truncus is no longer a possibility. Then, any others that you will exclude? Vinod wants to say, except TAPVC and single ventricles, others are rare in dextrocardia situs inversus. Why would you say so? I would say that situs inversus dextrocardia has the same incidence of congenital heart disease as in a situs solitus levocardia. So whatever can occur in a normal heart can also occur in a situs inversus dextrocardia. It does happen. For instance, transposition, simple transposition in situs inversus dextrocardia is common enough. Only 1 month ago, I had done a balloon septostomy in a situs inversus dextrocardia TGA, and we had sent that baby to arterial switch. So, situs inversus dextrocardia does not allow you to choose between the conditions. But from the basis of the available findings, truncus is unlikely. I would say even Epstein is less likely because there is an obvious cardiomegaly. Yes, there is no tricuspid regurgitation murmur that has been described. The second sound is unreliable because the baby findings are on day 11. So single second sound on day 11 is unlikely for Epstein. Rajesh, when does the second sound split normally appear in a baby? Forget this baby. When would second sound split normally appear in a baby? Of course, it comes after pulmonary vascular resistance comes down. So the question is, it happens in day 5, day 15, day 25, day 35. Choose. Mirza thinks it is 6 weeks. Vinod thinks it is 4 to 6 weeks. Any other thought? Rajesh likes 1 month. In fact, you're way off the mark. Normal second sound split can be appreciated from day 5 onwards. From day 5 onwards, the normal split or the second sound appears. You don't need to wait for the complete resolution of the pulmonary vascular resistance for the normal split to appear. Day 5 is the usual time when the split becomes audible. Okay, that was some digression. Now let Khalid present the case. Khalid has told us the differential diagnosis. To move further, we at least need the X-ray test and ECG. Let's see the X-ray and ECG, Khalid.
So this is the ECG of the child.
Yeah. Now I will ask again Mirza to describe this ECG. Mirza, I hope you can see the ECG. Let us know what you think. Yes, it is normal sinus rhythm. What do you mean by NAD, Mirza? Normal axis deviation? My God. In my time, NAD meant no abnormality detected. Avoid that expression, Mirza. I think the word normal axis deviation is extremely misleading. What is the axis in this baby? And how would you interpret in this context? The axis would be around plus 60. An axis of plus 60 in a newborn would be considered like a left axis deviation. Okay, there's so much about the axis. What else? Others can contribute. Mirza is stuck at the axis. You have a negative P in lead 1. Okay. Yes, Rajesh, you have noted that it is atrial situs inversus. Very good. And Mirza had already commented on the axis. Is there anything else that you would note as abnormal in this baby? There is a very important negative finding in this baby. What is it? This is a newborn. There is a very important negative finding. Anybody? You said progression of R wave? You mean non-progression of R wave from V1 to V? Dextrocardia, okay, I want you to notice it. No progression of R waves in precordial leads is a sign of dextrocardia. Having already noticed atrial inversion, the non-progression of R waves in precordial leads will confirm that you are dealing with situs inversus dextrocardia. That's fine, very good. But anything, mind you, we have a diagnostic list. We are trying to tick some in and tick some out. Remember our no Q waves in V6? Okay, very good. What would that mean if there is no Q waves in V6 in this case? Tell me, Vinod, having noticed that there are no Q waves in V6, what would be your inference from that finding? Anybody? Why are there no Q waves in V6 in this patient? Yes, LV is on the, no, if there are no Q waves in V6, LV is not on the left side, LV is on the right side. Correct, Vinod? We know that there are no Q waves in V6. it means LV is not on the left side. LV is on the right side. That is why there are no QS in V6. If Khalid had shown you a V6R, you could have perhaps noticed a Q. Yes, so that's a evidence of L ventricular loop. Okay, very good. So let me ask Khalid to summarize his findings. Khalid?
Yes. So this ECG shows arterial inversion dextrocardia with QRS of plus 60. There was lack of RV forces in V1 and LV left ventricular dominance.
Can you go back on that ECG, Khalid? Now, will you note, I was asking you what is the striking negative finding in this ECG? Situs inversus dextrocardia, you should make out, and I'm sure that you made out. But then look at V1. This is a newborn, and you expect a tall R in V1. Whether it is levocardia or dextrocardia, V1 will be related to the right ventricle. And you would expect a tall R in V1. The absence of a tall R in V1 would suggest that the RV is unimportant in this patient. And the DPS would suggest that LV is the dominant ventricle. Okay, so now come to your findings once again, your slide, Khalid. So my question to Rajesh, remember our diagnosis list. Given this ECG, are you able to go further from the differential diagnosis list? Does this ECG help you again in ruling out something and ruling in something? Rajesh, after you have seen the ECG, where have we reached in our diagnosis? Tricuspid atresia, very good. So tricuspid atresia is a strong possibility. Can you think of anything other than tricuspid atresia in this patient? Unbalanced AV canal with LV dominance, very good. So unbalanced AV canal, tricuspid atresia and unbalanced AV canal are strong possibilities after having seen this ECG. Okay, you have an X-ray, Khalid?
Yes.
Please go ahead and show us the X-ray.
This is the X-ray of the child.
Okay. Now, I hope all of you are able to see the X-ray. I want Rajesh to tell me the X-ray findings. Yes, situs inversus dextrocardia. Very good, Rajesh. Are you able to make out the lung vascularity? There is probably cardiomegaly because the heart shadow seems to touch the right chest wall. So situs inversus dextrocardia, cardiomegaly. Yes. And can you make out the lung vascularity? Looks like pulmonary venous hypertension. Very good. There is an increased pulmonary blood flow. From this transmitted image, making out whether it is arterial or venous would be difficult. It could be a combination also. But definitely there is an increased pulmonary blood flow. It is not a reduced pulmonary blood flow situation. Remember, we had that discussion earlier on and we had said that with a 90% saturation with this type of findings, it is unlikely that we are dealing with a cyanotic congenital heart disease with a reduced pulmonary blood flow. We are dealing with increased pulmonary blood flow. With the ECG, you have zeroed in on to tricuspid atresia and also to a possible AV canal defect, unbalanced AV canal, and AV valve regurgitation. Now, one more question to you. If this is tricuspid atresia and the pulmonary blood flow is increased, what are the circumstances in which tricuspid atresia would have an increased pulmonary blood flow? Mirsha? Remember, tricuspid atresia is a strong contender for diagnosis. Only Khalid knows whether that is so or not. But under what circumstances would tricuspid atresia have an increased pulmonary blood flow? Type C. What is type C tricuspid atresia, Mirza? Tell the others. I thought you would want to say type 1C. Yes. Yes, tricuspid atresia with PGA, which will be type 2, that will be a very high possibility when there is an increased pulmonary blood flow. Tricuspid atresia, you should always suspect that may be associated with TGA. But type 1C, which is tricuspid atresia normally related to great vessels and a large VST, can also be associated with that. So if pulmonary blood flow is to be increased in tricuspid atresia, either you should have a TGA or you should have a large VST. Khalid, what are your findings on the X-ray? Anything that we haven't seen? Tell us.
It's citation versus cardia with increased pulmonary blood flow. Actually, this is what the major which has been shown by X-ray.
Okay. So at this point, what is your diagnosis, Khalid?
We were thinking mainly the same as you, doctor, in tricuspid atresia with restrictive VST with increased blood flow. So tricuspid atresia.
So we are thinking of tricuspid atresia with increased pulmonary blood flow at this stage, and because of that right heart failure, you're also thinking that in this tricuspid atresia maybe the atrial communication is inadequate. So this is where we stand now. Now, does any other participant want to ask any question to Dr. Khalid? Because I would ask him to show his echo, but before that, if you want anything more, this is the time to ask it. Any questions? Did you put right-sided leads? Khalid?
Yes.
Had you put right-sided leads? But I don't think that's in your present.
No. Actually, we didn't. I didn't bring the other ECG.
Okay.
Yeah.
Okay.
No.
Vinod, here he has not to show the right-sided leads. He has chosen not to show the right-sided leads, but the left-sided leads in this case are sufficiently communicative. Yes, I'm sure that the complete ECG recording would have included a right-sided leading leads also. Okay, then let's have your. Can you show us the echo, Khalid? You have the echo clips?
Yes, sure.
Yeah.
So this is a subcostal view showing the aorta to the right and the anterior vena cava to the left. You can see here, this is the right atrium communicating to the left atrium, and please note the please note the foramen ovale and the pulmonary veins entering the left atrium.
So your left atrium is on the right side, correct? And the atria are inverted.
Yes.
Okay.
And this is apical four-chamber view from the right side of the patient showing tricuspid atresia, and this is the mitral valve. This is the RV, which is giving to the aorta. We didn't show the full course, but we'll show it later on. And here is the VST.
Where is the VST? Just point out the VST, RV, L and LV.
It's here.
That is the LV.
Yes, this is the LV.
Okay.
This is the pulmonary. This is the LV giving origin to the pulmonary artery. There is a pressure gradient to the valve, but this is probably because of increased blood flow. There is a pressure gradient for around 20.
20. Okay.
Maximum pressure gradient is 20.
Okay.
There is a trivial PR. And this is modified by seeing a long axis from the right side of the patient. As you can see, the aorta is to the right and anterior, and this is the pulmonary artery arising posterior and to the left.
I thought the aorta is to the left and anterior in that image, Khalid?
It's dextrocardia.
Is to the left and anterior in what you have shown, if your markings are correct.
Yes, yes, this is the left and anterior.
Okay.
Yeah. And this is the pulmonary artery, posterior and to the right. This is, we have a bigger picture than this. This is the aorta, which shows no coarctation. Actually, we didn't show it, but there is a large BDA entering to the pulmonary artery.
Okay. So, what is your diagnosis after the echo? Khalid?
Yes, doctor.
What is your diagnosis after the echo?
Yeah, show it. So basically, it's a status inversus dextrocardia with all pulmonary veins to the right-sided, atrium. There is a restricted AST, tricuspid atresia with hypoplastic RV. There was a large inlet muscular VST with left to right shunt. There is complete transposition of great arteries with aorta left and anterior with unrestricted pulmonary blood flow. There is also large BDA with left to right shunt.
Okay. Any questions that anybody has? I asked Khalid to give his diagnosis because I'm not sure whether the echo images were very well visible for you to draw conclusions. So I was not asking you to comment on that, but I hope you have seen it. Do you have any questions with regard to the echo or with regard to the diagnosis that Khalid has arrived at? Mirza, Vinod, Rajesh? Okay. Then there are a few things that you should note in this diagnosis. Remember, our baby presented with cyanosis and heart failure. We discussed the diagnostic possibilities, and remember, tricuspid atresia was one of the possibilities that you had pointed out. It eventually turned out to be tricuspid atresia. And in tricuspid atresia, if you're thinking of right heart failure, you consider a restrictive ASD as the reason for the right heart failure. But if the tricuspid atresia is associated with an increased pulmonary blood flow, it actually becomes a right and left-sided failure. A left heart failure due to the increased pulmonary blood flow and a right heart failure because of the restrictive ASD. And in this baby, Khalid told us that there was a large PDA also. And unfortunately, from the baby's point of view, the doctors who initially treated the baby kept the PDA open with prostin, which perhaps led to the initial worsening and even collapse of the baby. The increasing the pulmonary blood flow, dropping the pulmonary vascular resistance, and inviting severe heart failure. That would be the reason why this baby came with such florid right heart failure, in addition to the increased pulmonary blood flow that you have already seen. Now, Birsa, can you tell us how will you manage this baby if you were dealing with this? Before I ask Khalid what he did or what was done in his unit, how would you manage this baby? Here's a baby with situs inversus dextrocardia, tricuspid atresia, TGA, increased pulmonary blood flow, restrictive atrial communication. What would you do? You will stabilize first, very good. And let us say, let me ask Khalid, what did he do to stabilize the baby?
This child actually, when he came, he was ventilated, and his saturation was 91% on FiO2 and his vitals were within normal. So what shall I start? What we did in our unit?
I just want you to tell us what did you do to stabilize the baby. That's all.
Yeah. So we reduced the oxygen for this child.
Okay. That's it. What did you do to the prostaglandin?
We stopped the prostaglandin.
Okay, very good. So two important measures in stabilizing this baby were reducing the oxygen and stopping the prostaglandin. Do you agree with this? Are you happy that Khalid did this, or you don't like the fact that Khalid did this? Tell me. Vinod, do you agree with these two actions, or you disagree with them? You agree. Why do you want to reduce the oxygen? To increase PVR, yes, because giving oxygen only drops the PVR further, and therefore there is no point in giving oxygen to this baby. So you reduce the FiO2 to whatever level you can, make it room air if you can, and also you will stop prostaglandin because you don't want a PDA in this baby. That's already increased pulmonary blood flow. Baby saturations are fine. You don't want a PDA in this baby. Okay. Khalid, tell us what you did.
So in our unit at day 15 of life, we did at day 12 of life, this child went to balloon arterial septicectomy. Then we planned him at day 18 for BA banding and BDA ligation. The child is currently doing well and being planned for the next stage of single ventricular palliation by around 3 to 6 months of age.
Okay. Now, I think Vinod has raised the question as to whether we can use permissive hypercapnia to stabilize this baby. Yes, it is one of the things. When you are cutting off the oxygen, if you allow a PCO2 level of say 40 to 45, that is helpful in regulating the PVR to the advantage of the baby, elevating the PVR and reducing the pulmonary blood flow while you are waiting for a more definitive management. And here Khalid has described that the baby underwent a balloon atrial septostomy. Was there any pressure recording during the balloon septostomy, Khalid? Because it would be interesting to know.
Actually, before the balloon septostomy, the left arterial pressure was 16 and the right arterial pressure was 14.
Okay.
And after the septostomy, it was both arteria was 14 millimeter mercury.
Oh, okay, very good. I would like you to note that point. See, this baby had right and left heart failure. An LA pressure of 16 in a newborn baby will cause pulmonary venous hypertension. Remember, some of you thought that the X-ray had shown pulmonary venous hypertension. So this baby's left atrial pressure was high, which is related to the increased pulmonary venous return. The RA pressure is also high. 14 RA is quite high, and that is because the ASD was restrictive. Now, once you create a large ASD, the pressures do not come down drastically because the LA pressure is still high. It is shared with the RA. That is why both the pressures became 14. And subsequently, the baby has undergone a PA band, correct, Khalid?
Yes, PA band and BDA ligation.
Okay, very good. Now, Marsa, is there anything else that you would have done in the newborn period? Do you agree with the management? Or in your hospital, do you think the baby would have been managed differently? Can I have your response? Varsha, you're happy with the management? You're happy with the management. Then let me ask you a broader question. In the current era, What are the indications for PA banding in a newborn? You asked the question, why wait for 7 days for balloon septostomy? Vinod, I think the balloon septostomy was done on 1 day after arrival.
Yes, he actually arrived at day 11, and balloon was done at day 12. Right.
So there was no waiting period for balloon septostomy. It was done within 24 hours of arrival. Okay. So my other question, what are the indications for PA banding in the current era? Swiss cheese VST with increased pulmonary, okay. Multiple muscular VSTs, okay. Multiple VSTs with increased pulmonary blood flow. Yes, one. What else? Single ventricle with increased pulmonary blood flow to prepare for the next stage. Very good. Which perhaps the most common indications in the present era will be these two. A multiple muscular VSTs or a single ventricle with increased pulmonary blood flow to prepare for the next stage. Can you think of any other indication for doing PA band? For LV training in DTGA, very good. For late presenting DTGA, if you want to train the LV for a 2-stage arterial switch, you need to band the PA. Very good. Can you do it in corrected transposition also? In corrected transposition, why would you do a PA band? Yes, in corrected transposition with tricuspid regurgitation or with left AV valve regurgitation, let us say, it can reduce the left AV valve regurgitation if you cause a shift of the septum by banding the PA. If you want to train the anatomic left ventricle in corrected transposition, then again you need to band the PA. If you want to do, some people believe that in any corrected transposition, giving a loose band is useful in choosing the strategy for future to double switch if you want to do. But everybody would agree that if there is an AV valve regurgitation, if there is a left AV valve regurgitation, to control that, doing a PA band would be useful. Okay. These are some of the indications for PA band. Let's also remember, if you have a child with a Senning or a mustard, to convert that Senning or mustard into an arterial switch, you need to train the ventricle. For that also PA band could be done. If you look up some of the earlier issues of analysis of pediatric cardiology, there's a very nice review article by Dr. Rajesh Sharma on the role of PA band in contemporary cardiac surgery. Can you think of any adverse effect that can happen from PA banding in this baby? Khalid?
PA banding, actually it can
right sided when your aorta is from the anatomic RV. How does it, the effect of PA banding, how does it affect? Somebody thought that distal migration may cause PA branch stenosis. Yes, but in this particular anatomy that we are discussing, whether there is something that you need to be concerned about is the question. What will be your next single ventricle palliation?
Actually, we should think about DMSK, especially if unrestricted VSD. But here the patient is having unrestricted VSD still, but this needs to be evaluated.
Yes, as this child progresses, remember, whenever you have a condition where the aorta is coming from the RV and a VSD communicating, we will be concerned about that VSD size as the baby grows older. There is every possibility that as you are following up, the PA band may be associated with the occurrence of an LVOT obstruction, and the VSD may become smaller in which case the next stage of surgery cannot be simply a tight PA band and Glen. It may need to be a Damask with Glen. So whenever you have a restrictive VSD, then you must consider that the next surgical option may not be a simple Glen, but it may be a Damask. Are there any other questions that you would like to ask? Other thoughts that come to you from this case? Anybody? Any further questions? Otherwise, it's time to thank Dr. Khalid. Khalid, is there anything else that you want to say?
Yeah, I want to thank everybody and welcome all of them to Oman. It's a pretty place to visit and also a pretty place where you can find a complex, very complex heart lesions.
Well, thank you, Khalid.
Yeah.